Good morning to everybody. Thank you to be here today. We have an interesting session about persistent atrial fibrillation. Can we improve our results? This is a joint session between the European Heart Rhythm Association and la sección de arritmias de la Sociedad Española de Cardiología. And my name is José Luis Merino. I am on behalf of EHRA. I am the President Secretary of EHRA. And Luis Mon, I think that is representing both the La Sección and EHRA because he is coordinator of international relationships. We have three speakers today with a lot of experience in persistent atrial fibrillation ablation. The first one is Felipe Atienza. I think that you all know him very well. He has a long history of working in rotors and something more than the regular signals that we are used to work with. So I am looking forward for his lecture. The second one will be Christopher Piorkowski from Dresden, Germany. You probably also know him very well. He has published a lot in the atrial fibrillation ablation field, and he has a very interesting talk on scar ablation. Finally, we have Edouard Gitenet from Marseille, France. They have recently published a paper on special temporal dispersion of electrons in persistent atrial fibrillation. So I think that this will be also an interesting lecture. So without further delay, we start with Felipe. Felipe, please.
Good morning, everybody. Thank you very much to the organizers for the invitation to participate and talk. Oh, I did something wrong. Okay. And talk about the sick of rotors. As José Luis was saying, we've been working in trying to find rotors for several years. It is a fascinating area, and I'd like to keep this time to talk to you about this topic. These are my disclosures. The outline will be the following. We will be talking about definitions and detections of rotors, the reliability of body surface recordings to detect rotors. Are they a target for ablation? What is the relationship between AF complexity and the stratification of atrial fibrillation, and conclusions? As you all know, classical epicardial activation mapping is unable to record reentrant rotations, sustained reentrant rotations. What they are able to record are foci and breakthrough sites, but no reentry was demonstrated by works by Alessi and Waldo groups. However, as you can see here, intracardiac recordings have several problems, and they have problems with false positives and false negatives detections. Other systems to record using endocardial and epicardial mappings from different groups, the Fedorov group, the Narayan group, and the Kalman group, have been able to record transient rotors returning to constant anatomic locations that tend to rotate 2 to 6 occasions with a central core, meaning which of those two theories are true? Who is right? Who is right? Like here, everything will depend on the crystal that we use to look to things. Can be either focal, no reentrant, or multicolored rotation areas. Let's see who is right on this area. Using sequential and body surface mappings, rotational areas can be detected, but this is just a matter of luck. You have to be constantly mapping, and whenever you are in the right spot, you can record reentrant rotations, here with several examples published in the literature. But the most compelling evidence from the presence of rotations comes from the group of Narayan, who using biatrial basket recordings, intracardiac recordings, have been able to demonstrate the presence of rotations that sustain atrial fibrillation, and that can be eliminated during radiofrequency ablation. However, these two different ways of recording intracardiac rotors are different. When we use multipolar regional catheters, or we can use the low-resolution basket catheters with 64 bipolar recordings. The difference are that multipolar regional catheters, that is the lasso catheter, the pentarite catheter, can accurately detect and track rotors when they are placed over the rotor core, only then. They are very specific, but their sensitivity is low and you have to spend a lot of time mapping around the atria. In contrast, the basket catheter is a low-resolution catheter and can detect rotors and track the trajectories, the movement of the rotor, but they are prone to detect spurious rotors, that is, rotations that are false due to the presence of linear block, such as the crista terminalis, etc. So they are highly sensible, but their specificity is very low. This is the phase map that is measured. This is the way that we can use to map a rotor using a specific way of processing signals, which is the Hilbert transform. And the problem of this method is that has been mostly validated in animals, and the demonstration in humans is very poor. There are few examples, such as the Fedorov case, but no real-life cases up to date have been published. And there are false associations. There are reentrant activities demonstrating the presence of rotors which are not due to permanent rotations. The rotor ablation hypothesis is that when we obtain one of those rotors, we are able to record a rotor histogram that enables us to detect where the rotor is turning around, and we can deliver such a line that I was showing in the slide. Anyway, I will fade it out. Anyway, the presence of the rotation enables us to target it with ablation, but the problem is how to record it. We have several limitations in electrogram-based contact mapping. The problems that I already commented, the problem of local versus far field recordings, the problem of using either bipolar or monopolar recordings, the problem of being sequentially mapping the atria or map it with lower resolution globally with basket catheters, the problem of recording from the endocardium or the epicardium and the dissociation between these two sites, and the problem of using automatic algorithms that we don't really understand. Is there a role for body surface mappings to detect rotors? In 2009, the first group that recorded short-lived rotors was the group by Guillen, now working with our team, and they were able to record short-lived rotors with a rotation, partial rotation during the T wave, TQ wave intervals. They were relatively stable, but they were very short-lived. And 1 year later, in 2010, the group of Kuklik, that most of you we already know, reported very similar reports using a preliminary system of the CardioInsight. Later on, in 2014, the group of Heisiger developed and published this very relevant paper using the body surface recording system that was able to detect reentrant rotations and foci that were maintaining atrial fibrillation, and they targeted those sites that tended to occur always at the same sites in the atria, such as here or there, painted in red. And with this aim, they were able to terminate a very relevant number of patients with persistent atrial fibrillation. This is the method that the CardioInsight was using. They used BEST with 2,050 electrical recordings. They made the recordings. Let me see if I can move here. They made the recordings, and they also obtained a CT scan or MRI able to obtain the atrial 3D reconstruction and perform the software inverse solution to calculate where the epicardial rotations are located in the atria. But how reliable are these rotors detected from the body surface? Can we trust them? Are they artifacts? Can we believe them? A few years ago, we started in collaboration with the Stanford Hospital, we started a validation trial to compare using intracardiac basket catheters in the left and the right atrium and compare the recordings in the endocardium with those recordings obtained from the body surface in our patients. We included a total of 47 patients having simultaneous intracardiac and non-invasive ECG mapping. And we were able to see that on the A panel, we were able to identify a rotational pattern, sustained rotational pattern as shown by the intracardiac electrograms and the phase mapping in the right appendage. And this area corresponded very well and very nicely with that one recorded from the inverse solution reconstruction from the body surface ECG. Later, we obtained what we call the histogram maps that are able to point in red the areas with the most consistent rotational presence. That is, the rotor either turns twice, 3 times, and then disappears, but tend to recur to that area. So those areas with high recurrence of rotations are painted in red. And there was a very nice, as you can see in the B panel here, there was a very nice correlation between the rotations observed in the endocardium with the basket catheter and in the epicardium in the inverse solution obtained with the body surface recording. And those sites with high prevalence of rotations in the electrograms, there was also, with low prevalence of rotations in the electrogram, there was also very low presence in the body surface recording, and the other way around. Those areas with higher recurrence of rotations in the intracardiac electrograms had a high recurrence of rotations in the body surface recordings. But are rotors a true target for ablation? Can we ablate them and terminate, or this is just a fancy way of looking at the electrophysiology recordings in atrial fibrillation? Here you can see an example of a patient with a persistent atrial fibrillation in whom we induced a phase mapping that is showing us a rotation, constant rotation around an area located close to the right inferior pulmonary vein. The reentrant activity histogram shown below points in red to that area close to the inferior pulmonary vein. When we use the intracardiac electrogram recording using the RISE system developed by Dr. Arenal, there was a very consistent activation site at the right inferior pulmonary vein. So there was a correlation between that rotational area found in the body surface recording and what we were recording with the intracardiac electrograms. And pointed to that site, to the right inferior pulmonary vein, atrial fibrillation was able to be terminated. Similarly, this is another case, more complex case. This is a patient with a valvular disease in whom we were able to record a rotational area from the body surface. This is a phase mapping in whom we recorded the activation in the left and the right atrium. This is a posterior view, and we see that there is a rotational area that is going, disappearing, but turning back always to the same area in between the both inferior pulmonary veins. When we take a look at the PA view, we can observe that there is another rotor, a second rotational area, located in the right lateral atrium. The reentrant activity histogram points in red those areas that tended to recur the rotational sites both in the posterior left atrium and in the right atrium in the PA view. We started ablating, performing wide antrum circular ablation of the atria, of the left atrium, and we observed that when we were finishing the circuits around the pulmonary veins, atrial fibrillation, as you can see on the left panel, turns to an atrial flutter. And this is the map that we sequentially were able to obtain in the right atrium. And as you can see, there is a rotational site turning around in the right atrium, maintaining the atrial flutter that remains after the PVs were isolated. As you can see, the reentrant analysis histogram shows it in red. This is the correlation between the body surface recordings and the endocardial recordings. And this is the result of ablating in the right atrial wall. Termination of the atrial flutter turning to sinus rhythm. Therefore, atrial fibrillation can be terminated when targeting the reentrant sites, the rotational reentrant sites. When we are using basket catheters, not every single site of the atria is covered by those catheters. And there may be sites that are not covered. Sometimes patients cannot be terminated. And the patients that cannot be terminated when we are ablating using these multi-contact catheters are sites that cannot be reached with the basket catheter, as shown in the slide that termination patients had lower number of sites outside the body surface recording area, while non-terminating patients had sites that couldn't be reached by the basket catheter. So this is a complementary technology to the intracardiac recordings. So we can monitor the evolution of atrial fibrillation complexity either day by day or during the procedure, being able to watch what is happening to the ablational process. In the meantime, we are ablating the patient. And to finalize, I will talk a little bit about AF complexity and AF stratification. When we are targeting patients in whom we are going to perform only PV isolation, we have been able to demonstrate that those patients in whom, in the A panel, we are able to see that the histogram points to the pulmonary veins, also other sites, but also mostly to the pulmonary veins, those patients can be terminated while ablating. While patients in whom there are sites, histogram sites outside the pulmonary veins, are less able to be terminated. So the cingulary point, the rotor's presence outside the pulmonary veins, tends to be higher in patients that are not able to be terminated during ablation. Similarly, when we are ablating patients isolating the veins, but also ablating outside the veins, those patients in whom the prevalence of sites outside the veins is larger, with larger numbers, are less able to be terminated when we are performing radiofrequency ablation. This has also been shown by the group of Heitziger, in whom they demonstrated that patients with longer duration of atrial fibrillation had more reentrant sites outside the pulmonary vein, and those patients were largest in those that AFib was lasting more than 12 months. However, they only consider duration of AFib. And we have observed that certain patients with persistent AFib have simple rotational patterns with a histogram with very small location sites like this, in whom ablation, a point ablation at that site terminated AFib. In contrast, paroxysmal patients that sometimes we consider that are easier may not be the case. And for example, this patient, who was a simple paroxysmal AFib patient, had multiple reentrant rotational sites widespread in the atria. And of course, ablation was ineffective in this patient. Not effective acutely and not effective in the long term. So when we consider, I'm finishing, when we consider how the complexity of the body surface recording is related to the termination of atrial fibrillation during ablation, we can see that patients that are not able to be terminated during ablation had a higher number of sites, rotational sites in the atria, as compared to those patients that were able to be terminated during ablation. But when we classify patients between paroxysmal and persistent, there was no difference. So the classical stratification sites talking about paroxysmal or persistent was not able to tell us which of those types were able to be terminated during ablation. And as you can see in this slide, the probability of terminate AFib was similar, closely to 1, between persistent and paroxysmal. Therefore, it's not the classical classification of patients between paroxysmal or persistent, the ones that predicts AFib termination, but the complexity, the electrical complexity of AFib, the one that will tell us which of those patients will do better during ablation. This is the classical AFib stratification, classifying patients between paroxysmal, permanent, or persistent AFib. But this is the same model that we've been using for the last 30 years, and as I demonstrated in the previous slide, this is unable to help us how to better treat AFib patients. This is the way we proceed to treat patients with atrial fibrillation, but we propose a novel way to classify patients, and instead of using the body surface recording used by the Cardio Insight system, we propose to use a 3D reconstruction that avoids the use of the CT scan or the MRI that can be performed either in the clinic or during the ablation procedure to obtain the same epicardial potentials in the body surface recordings. And our proposal to guide treatment of AFib is using this system to identify those patients with low complexity, that is, very small number of rotational patterns in the atria that can be either managed with drugs or PV, mostly PV isolation, or targeting those sites outside the PV. And those patients with high complexity body surface recordings with many sites in both the left and the right atrium. In those patients, we can either decide, it was the very last. How can I return to the? Okay, someone is helping me.
Yo creo que eso es un modelo no del paciente, sino es un modelo no independiente.
Okay, this is the last one. So patients with high complexity, many rotational sites around both atria, we can either choose between rate control or perform extensive ablation of AF drivers to try to modify atrial fibrillation. So in conclusion, body surface recording, ECGI, enables global of the whole atria, non-invasive atrial fibrillation mapping, and is well correlated with intracardiac atrial recordings. The current methodology uses inverse solution reconstruction without the need to use MRI or CT scan. The real-time recording can be performed during the procedure, before the procedure, and after the procedure. Sequential recordings during the disease process may help. And driver complexity clear points to the success of ablation and will allow a better AF clinical stratification based on electrical parameters. I have to acknowledge the contribution of these institutions, the participation of the group from Hospital Gregorio Marañón, the group of Stanford, Universidad Politécnica, and Michigan University, and I thank you for your attention.
Is there any, no, wait, no? We will do the questions now?
At the end.
At the end? Okay. Let's continue then. So now we'll proceed with Dr. Piorkowski. He will talk about scar ablation, so the ablation directed with voltage, I guess, and see the results. Thank you.
Dear Louis, dear Jose, ladies and gentlemen, thanks for inviting me. Thanks for having me here. I bring the greetings from my German colleagues to the Spanish Society to the annual meeting, and it's a pleasure to be here. My topic is persistent atrial fibrillation, the role of scar ablation. And these are my disclosures. And during my talk, I would like to discuss a couple of points. First, I would like to indulge a little bit into the question, what means persistent atrial fibrillation? What is a patient with persistent atrial fibrillation? Then I would like to talk about the ablation strategy of substrate-based, voltage-based ablation and the outcome, also about the limitations and potential further developments. To answer the question, what does persistent atrial fibrillation actually means, I've pulled up a study which is not entirely new. It was published in 2014, and it attempts to compare the clinical classification of atrial fibrillation patients with the actual temporal persistence. And the data were obtained from pacemaker patients. This study that is shown here summarizes the data from the TRANS and the OMNI studies. These were 1,200 patients with continuous monitoring through the implanted device. And these were the patient characteristics. There were about 1,000 patients with paroxysmal atrial fibrillation, 100 patients with persistent atrial fibrillation. They were followed up for at least 1.5 years. And these are the respective patient characteristics. What was interesting to see is that we, as a physician, in our clinical classification of our AF patients are frequently wrong. Here you see the clinical classification, and here you see the device-derived control, the device-derived classification. And what you see is that about 20% of the patients who were deemed to be paroxysmal AF patients were actually persistent or permanent AF patient. And of the patients of whom we thought that they were actually in persistent atrial fibrillation, half of them had self-terminating episodes and were actually paroxysmal AF patients. So the clinical classification on the temporal persistence, paroxysmal and persistent, is quite often wrong in our patients. The other question is, what does it tell us about the underlying disease status actually? And here I have two case examples. One case example is a case example of a 62-year-old male patient with non-ischemic cardiomyopathy, ejection fraction 35%, has quite a big left atrium of 60 millimeters, had in the past cardioversions and eurythmic drug trials, and was then persistent since 2010. There's another case with almost the same clinical vignette, also quite a young guy with non-ischemic cardiomyopathy, also poor ejection fraction, large left atrium. He's, in addition, had a left bundle branch block and was also in persistent atrial fibrillation since 2010. And what I show you now are the voltage maps and sinus rhythm of the left atrium of these two patients. On the left-hand side, you see a left atrium which is essentially healthy. There is no low voltage, there is no fibrosis, there is no scarring. On the right-hand side, you see a left atrium which is severely diseased with a severely degenerative disease process on the myocardial tissue level. Both patients are clinically in persistent atrial fibrillation. So again, this clinical classification of persistent atrial fibrillation does not really help us to stratify these patients and to understand the underlying disease status. And this is a problem when we look into published data on treatment outcomes of patients with persistent atrial fibrillation. The most well-known study is the STAR-AF study. The STAR-AF study, you all are aware about it, told us that no matter what we do, we always end up with 50% success rate. Whether we do PVI or PVI plus lines or PVI plus defragmentation, it's always 50% of the success rate. Now keep in mind what I've just said. All of these were persistent AF patients. The question is, were they really persistent? Did the temporal permanence really fit? And what was the underlying disease status? So I would assume that this is a mixed population of all kinds of different patients. And that we end up with 50% is indicative that in some patients we ablate too little or at wrong positions. In other patients we ablate too much. So the problem is the presence of a standardized ablation concept and not an individualized ablation concept which treats the individual disease in a given patient. That's one of the main limitations of all published data and treatment of patients with persistent atrial fibrillation. And I was so happy to hear the talk of the previous speaker because he exactly came to the same conclusion. So what could we do better in the future? Could we individualize our treatment? I think, yes, we need to. What are the methodologies that we have in our hands? I think in principle there are two ways to approach this. One way would be analysis that are being performed during atrial fibrillation in a sense of an electrophysiological-like mapping procedure. And the other approach is a more substrate-based analysis that is performed mainly in sinus rhythm. When we think about the first one, this is all that we know, that is the work that has been done in rotor analysis, café mapping, AF activation mapping with or without contact, body surface mapping, etc. All of these are kind of mapping approaches. And I'm personally not sure whether this is the easiest and the best way to approach this. But it's a valid approach. The other approach is a substrate-based approach, which goes more back to an approach that we also use in patients with ventricular tachycardia, for instance, which is also a complex degenerative substrate. And this is the approach of voltage mapping, of sinus rhythm voltage mapping, not voltage mapping in AF, it has to be done in sinus rhythm, and this also goes a little bit into this direction, is substrate mapping or imaging that comes from imaging procedures. And especially here in Barcelona, in Louis' group, this is something, this is extensively investigated. So these are, in my opinion, the ways that individualized ablation of atrial fibrillation, persistent atrial fibrillation, could be approached in the future. And our personal experience very much comes from sinus rhythm voltage mapping. The first data that we acquired was in this study, and this shows you different clinical situations that you can meet. You can find a healthy left atrium, you can find a fibrotic and a severely scarred left atrium. And based on this mapping information, based on this substrate description, an individual ablation concept is being defined for this patient, and we've done this since almost 10 years now. This was published in 2014, and I would like to summarize the treatment principles. One treatment principle is to not ablate healthy tissue. So if there is no low voltage, we don't do anything else except a pulmonary vein isolation, even if this is a patient with persistent atrial fibrillation. And you would be surprised how often that is the case. About 50 to 60% of the patients presenting with persistent atrial fibrillation have no low voltage when you do a voltage map in sinus rhythm. So in those patients, this ablation approach actually limits ablation. It makes it less complex, it makes it easier, it makes it faster. If there is low voltage, then we really look for the extent and the localization of these areas. If these are small areas, we try to take them out by local ablation, always connecting it to an anatomical boundary in order to prevent reentrant tachycardias around it. And the endpoint is loss of local pace capture. If these are larger low voltage regions, such as in the example here in the middle, then we really take out entire segments of the left atrial wall that are affected by the degenerative disease process, for instance, the posterior wall of the left atrium. Now always comes the question, now what about the atrial transport function? Well, such a left atrium, such a fibrotic wall does not pump in sinus rhythm, nor does it pump sufficiently when you take out the posterior left atrial wall. And we have data on this from MR strain that the impact on atrial transport function with this approach is not deleterious. Again, one of the main principles is to make the lesions complete, and to connect them to anatomical obstacles such as pulmonary veins, mitral annulus, SVC, IVC, whatever, in order to prevent reentrant tachycardias around it. And this is one of the most challenges as well. To always create this completeness of block in the ablation line. Here is a schematic drawing summarizing this approach again. The first example is an example with a circumscribed localized area which is being homogenized at the mitral annulus. Here is a large low voltage region at the anterior wall with an anterior line, and here the entire anterior wall segment of the left atrium is being taken out. There are numerous data, single-center experiences on this kind of approach in patients with persistent and paroxysmal atrial fibrillation, by the way. Single-center randomized studies, but no multi-center published evidence. There is one multi-center study ongoing. It's the ERASE-AF study that we perform with 5 to 6 other centers in Europe, and we are about to enroll 350 patients, which are randomized for a pulmonary vein isolation only versus a voltage-based ablation arm. And I think we will complete this study in terms of inclusion in this year. We have 40 more patients to go to complete the 350 patients, and then we go only into the follow-up phase, which will be done with implanted loop recorders. And this will create the evidence for this approach, we hope. But we have an idea where we are sailing, and I want to show you where this idea comes from. As part of our ablation program in Dresden, we have an intensified monitoring of all patients that undergo ablations. Every patient in our institution gets a loop recorder after ablation. And we've published some of this data here in this analysis, and I want to show you the outcome in the patients with persistent atrial fibrillation. In this analysis, these were 419 patients with an implanted loop recorder, half of them paroxysmal, half of them persistent atrial fibrillation. They were ablated between March 14 and September 16 with a mean follow-up of 15 months. And in this follow-up period, every single episode larger than 2 minutes that was recorded by the device was counted, was looked at, was manually adjudicated, and was incorporated into the rhythm outcome analysis. What was interesting is to see the rhythm outcome in these formerly persistent AF patients. They have very different rhythm profiles, and this is incapable to be caught with just Holter recordings. You have the patients which are completely free, over years have not an AF episode again whatsoever. Then you have this typical picture of healing periods within 1 to 3 months after the ablation procedure. And we have observed suddenly healing periods which extend up to 6 months, as in the last example. And these are typically persistent AF patients. They have longer and more complex healing phases and rhythm profiles. And in these persistent patients, we also more frequently see something like this. They are free for 1 year completely, and then they have a single cluster, and then they are free again. And again, this is something that you cannot count with a Kaplan-Meier curve. This is something you cannot calculate with Holter. You need continuous monitoring to see that. Then there are, of course, the true late recurrences, which are free, and then they continue to fibrillate again and need treatment again, and then there are failures who have a significant amount of atrial fibrillation throughout the follow-up period. These are the different rhythm profiles, and because of this, I think we should stop talking about Kaplan-Meier curves and look more into burden. And this is more also like in the pacemaker patient. This is what we did. We looked into the AF burden from the ablation procedure, from the implant, through the entire follow-up. There was no consideration on healing phase. The individual healing phases were completely neglected, and we defined success as patients who did not have atrial fibrillation at all or had a really low subclinical AF burden, and the threshold that we put was 0.1%, an AF burden of 0.1%. That means the patient has less than 10 minutes AF per week. That was our definition of success, and if a patient previously was in persistent AF and then has a burden of less than 10 minutes per week over 15 months of follow-up, this is probably a successful procedure. And it was very interesting to look into the data of the paroxysmal and the persistent patients. Look here. With this definition, 2/3 of the formerly persistent AF patients were successfully treated. And this number is not so much lower compared to the paroxysmal patients. It's just 10% lower. So the persistent AF patients are doing pretty well. Of course, there are a few less patients with complete freedom from AF, but the rest only has some subclinical AF, which even is also frequently asymptomatic, and the relevance in terms of stroke and heart failures and prognostic risk factors is really debatable. So I think besides the ablation strategy, we also need to talk about new endpoints, which are more clinically oriented. And with this analysis, I would say with such an substrate-based approach, with a single procedure, off antiarrhythmic drugs, 99% of these patients were off antiarrhythmic drugs, we are able to successfully treat 2/3 of the patients with persistent atrial fibrillation. And this is how we educate our patients. We tell you, you have a 2/3 chance with one procedure that you will be better off and that the arrhythmia will be successfully treated based on this data. But 2/3 is not 100%. So let's talk at the end a little bit about the limitations of this approach. And there are limitations. The limitation is the voltage cutoff. We work with 0.5 millivolt. This is arbitrary. That may be different in different sections of the left atrium. This is something which has to be underlined with more research. There's an issue of electrospacing. Electrospacing determines the voltage map. And, of course, there's an issue of catheter orientation towards the tissue, which influences your voltage map information. All of these are limitations, and all of this will lead to new approaches in terms of multipolar catheter developments to improve the validity and the content of these voltage maps, and you're all familiar with these kind of developments. There's another, and I think a more principal limitation in terms of what is the conduction abnormality in the left atrium that we are trying to map. Fibrosis and scar is the conduction abnormality that we capture with voltage map. But it's not the only conduction abnormality that creates reentry that can sustain atrial fibrillation. We know that mechanical stress can lead to gap junctions lateralization. Gap junction lateralization makes reentry. Reentry makes atrial fibrillation. Voltage map is not able to capture this. So there are conduction abnormalities that we do not see with voltage maps. Another scenario that we do not see is the epicardial surface. The voltage map that we do today is endocardium, left atrium. That's it. On the epicardium, we are not mapping. And there are good data, experimental data on endoepicardial dissociation. There's a whole lot of epicardial fiber network, which is largely independent from the endocardial left atrial surface that can make conduction abnormalities and reentry. And our current method of voltage map does not capture that. And because of this, to the conclusion of my presentation, I would like to show you our concept of advanced redos in these patients when they come back. And this is a combined endoepicardial procedure. A catheter interventional endoepicardial procedure, not surgical. We do this with a subsulfate puncture. So if patients come back with at least 2 previous AF ablations, with recurrences of arrhythmias, with completely isolated pulmonary veins, then we perform this kind of sinus rhythm voltage map from endo and epicardium for the left and the right atrium. And we look for low voltage, we look for transmurality of ablation lesions, and we look for conduction abnormalities beyond low voltage substrates. And these are just some examples. Here on the right-hand side, you see the endomaps from the right and the left atrium. You see the epi map, and you see low voltage regions which are transmural. You see it here, the posterior wall, which is actually larger at the endocardial surface. You see it here in the epicardial surface. You see a low voltage region in the lower paraseptal space from endocardial, from epicardial. And then you see something which is only represented at the epicardium. It's a low voltage region between the superior and the inferior cable vein. And this is a typical location that we have found where the endocardium still looks normal, but the epicardium is affected by low voltage. This is interesting when you think about the combination of atrial fibrillation and sinus nodal disease. That's a different example where the value of such an approach becomes visible. This is about completeness of lines. This is a patient with a previous anterior ablation line. And when you analyze this from endocardial with the CS catheter and the lasso catheter and the appendage, you think it's blocked. You think there is propagation of the activation around the mitral annulus, and that's it. When you look epicardial on the catheter here, right at Bachmann's bundle, you see there's concealed conduction over Bachmann's bundle, purely epicardial, and the line is not blocked, even though you think it might be. And you need epicardial ablation to really block the Bachmann's bundle and to get reversal of activation in this epicardial fiber network. And then, I think that's the most interesting thing, that's what I referred to at the beginning. There are conduction abnormalities purely associated to epicardial fiber network and not necessarily to low voltage. This is a patient with completely normal voltages, with isolated veins and AF recurrences, and suddenly in the epicardial area of ligament of Marshall and Bachmann's bundle, we started to record this kind of potentials. This is like 2 propagation wavefronts that propagate opposite to each other. And we didn't know what it is. We could not interpret it until we recognized this is probably propagation in the epicardial fiber network through Bachmann's bundle and through the lower interatrial connections. And only after we blocked Bachmann's bundle, we could confirm this, because then one limb of this activation front was blocked. And this is a beautiful substrate for reentry. This is a conduction delay in DKNAF 1-2 of 130 milliseconds in sinus rhythm. Imagine how much reentry you can obtain out of this abnormality. And it was purely epicardial. On the endocardial surface, you didn't see anything. And this is another example to this. Here the catheter is looped epicardially around the appendage, and you see that the atrial component of the electrogram has actually 3 components. The atrial signal has 3 electrogram components in sinus rhythm. They are divided by each other up to 125 milliseconds. And only after you blocked the entrance from Bachmann's bundle and ablated Bachmann's bundle and made an anterior line, this conduction abnormality somehow improved. And this, again, purely epicardial and not related to low voltage, is something in the fiber network. So ladies and gentlemen, I would like to summarize. I think it's valid to say, and I completely agree with the previous speaker, Dr. Fernández, that persistent atrial fibrillation is an ill-defined patient population and nomenclature. For the true temporal persistence of the arrhythmia, which we cannot capture without continuous monitoring, and for the underlying disease status of the actual degenerative disorder in the atrial myocardium. And therefore, it's time to change terminology, classification, and thinking. Paroxysmal and persistent atrial fibrillation should be to a larger extent replaced and maybe changed into something like complex and less complex AF, substrate positive, substrate negative AF. It's open for debate. And then we will also improve our individualized ablation concepts for these patients. The interesting part is really the nature of the substrate and the subsequent conduction abnormalities. Currently, in the EP lab, fibrosis and scarring is easiest to identify because our mapping systems are designed for this from the time of when VT was targeted for ablation. We just take the same algorithms, and now we use it in the atrium, and therefore this is easy for us in a clinical setting, and it's already changing to a large extent the procedure and the clinical outcome. I've shown you the data, but we also should be aware that there are other conduction abnormalities that we need to explore in the future, and that the whole pathology does not stop at the endocardium. Thank you very much.